Our next speaker is John Park. He's one of the course directors, so you've seen his picture flashing across the screen here. Dr. Park is a pulmonary critical care physician, Mayo Clinic, Rochester. He is multifaceted in his interests, including a strong interest in quality as the quality chair for his division, the vice chair of quality for hospital critical care independent multidisciplinary program. He's also the associate program director for critical care medicine fellowship program, as well as the medical director for Enhanced Med, which is our moonlighting service. So welcome, Dr. Park.
Thank you. I guess I'd like to thank the course organizer for the invitation, but I guess that's me in part, so I'll move on. So the topic of the next, 40 minutes or so is and what we need to do to try to help keep our patients out of the ICU, and obviously you've heard some great pearls from Dr. Keller. I have really no financial conflicts of interest or off-label use. And I guess in my years of practice, I think really it boils down to like three different things I thought would be really helpful in what we can do to keep patients out of the ICU. Something that we always talk about, and historically we talk about certain providers being the wall. But I thought in this political climate, maybe that's not such a good idea. But that is still, at least we talk about, so to be fair, we always talked about someone's a wall. The other, I think, effective is just saying they're closed. And we've had this often where some of the ICUs and some of the outlying hospitals are actually closed, so they have to be deferred to us. And then certainly no vacancy. So these are the three pearls I thought I'd share with you. But to be fair, obviously, the ICU and the intensive care unit is there for a purpose, so if anyone needs to be there, obviously they need to be there. But my point in the next 40 minutes or so is to be, what things can you do when patients arrive to your unit, to your floor, and be attentive to their things and see what we can do to try to help prevent that potentially unnecessary admission to the ICU. And why is that important? Well, there's a study published in Critical Care Medicine in December of last year, so just a few months ago, really looked at the outcomes of our older patients ending up having an RRT and coming into the ICU. And unfortunately, not surprisingly, by the older patients, it seems like as I get older, that older number goes up. So it's more than 75, greater than or equal to 75. And you'll notice that their mortality is actually higher, and that's not surprising. So if they had an unexpected admission to the ICU, they have increased risk of mortality. And even in those who survive, they're more likely to go to a nursing care facility, which is something that not all of the patients necessarily prefer. And it turns out that among those who actually had goals with care discussion, actually it's a very smaller number who was admitted to the ICU. And what does that mean? I think it's also important that we really talk about goals with care, and we'll touch on that at the very end. But this is why I think it's an important topic. Not that we don't take the patient to the ICU